Anyone here doesn't know who is Chris Bombardier? Well, he is not the president of the World Federation, sadly.
Not yet.
But it is the person with hemophilia who has climbed highest peak in the world. But he's more than that. He's a leader. He has been involved defending the rights and looking for how it's possible to improve in hemophilia. And beside him is Baiba, who Baiba has been leading and making many efforts, not just in her country. She has been working and defending the right for the women, including in front of the WFA General Assembly, asking why women is no more incorporating our activities. As I said during the plenary yesterday, I hope in 4 years at least, no make distinction between women and men. So hemophilia is hemophilia. So today we want to talk about certain points. As you know, the situation, the life, the environment has been changing. Hemophilia has been changing, and it will still changing in the next 2-3 years, and maybe later, of course. But the leadership, I'm not so convinced that we have been changing at the same time. So that is something that we must be adapted to the new realities. And for that reason, we are here. One of the topics that I think that we have to cover and consider, for example, is if we are effective as leaders trying to convince the decision makers. So we are so effective, really. We are using the right tools. We are developing the right speaks, or is something that we need to implement and to change and to be adapted to the realities. I remember the exercise from the WFH in the past. All time teach me I have to talk with the Minister of Health. Maybe the minister is not the key person. Maybe the minister is not the most important. He's the most important person because he will sign. But in many countries, the minister is the person who doesn't know anything. It's just a political. It's like me, for example, the president. He's not the most important person. He's the most important leader, but not the person. The most important are each of you. So that is something that we need to learn, how to be effective and address our effort to whom. So for that reason, I would like to address several questions to my colleagues here. Not so bad, not so difficult question. Please start by introducing yourself and by sharing a brief overview of what diagnosis looks like in your region of focus. In your case, you have been working and visiting several countries.
Yeah.
What do you think with everything related to AHAFES?
Yeah.
Share with you.
Yeah, so my name's Chris Bombardier. I'm from the United States. I grew up in a place called Colorado with lots of mountains. I guess that makes a little bit of sense. I have severe hemophilia B, and I was really fortunate to be diagnosed within a day or two of being born. My mother had two uncles with hemophilia B who had both passed away before I was born, but she was able to at least know if she had sons, right, to have them tested. And so, hemophilia has always been a part of our family and our life from that point on. It was a pretty shocking discovery for them, but, how's it going? It was nice to be diagnosed that early on, though, to be able to, be connected to a treatment center back in the 1985, which I guess, now you guys know how old I am, but which I'm feeling older and older now, but not that old, I guess. But anyway, sorry. So yeah, I think having at least that generational awareness of hemophilia was really crucial in my diagnosis. Having that family history, knowing what it was, 2 generations above me, it was a huge advantage, and I was able to be connected to the treatment center from your early age, access to good treatment, medicine, and always encouraged to, be active and healthy and pursue goals and dreams, and I think being able to have that experience, led me to kind of have these big dreams of climbing the Seven Summits, which is the highest mountain on each continent. So I feel very lucky to just be born where I was and have that generational awareness for hemophilia and treatment centers already built up. And I would say in the U.S., we're still doing quite well diagnosing severe hemophilia. I would say most of those cases are identified fairly early on. But I think mild hemophilia and then, women and girls getting diagnosed is still a place that's lagging behind a great deal in the U.S. And I think shifting that also generational awareness of where people think only men can have hemophilia, that's got to take a huge shift in our country for diagnosing mild and women with hemophilia.
Your case, for example, is very interesting because for sure everybody thinks that in the United States everything is okay. So how many patients are living in the United States? You have a number?
I think we're close to around 20,000 people in the U.S. And I still think, there are a lot of challenges in more rural areas too in the U.S. U.S. is a very, very large country. And I think, very rural hospitals, especially with mild hemophilia and women and girls, those cases aren't getting diagnosed as well. So I think there's got to be a lot of work, with education in those areas as well still.
So you are a lucky man because you live in Boston, but what happened with someone who lives in Montana? The Yellowstone series, the Netflix series, I recommend you. It's a wonderful series. Nothing talking about hemophilia, but the situation could be different.
Oh, absolutely. I have several friends that live in Montana, and their access to treatment is vastly different, right? Their treatment center is in a state called Colorado, which is where I grew up, which is, a 14-hour drive, So luckily our treatment center would do outreaches, but if there's, a severe bleeding episode, it's all, telehealth. They're not actually getting in, or they're getting, flown to Colorado for actual, severe medical emergencies. So, those rural areas are still having, some different challenges.
So, thank you. Thank you. So, I jumped to Baiba, who has been working in your country, locally, and the region as well. So what needs to happen at local, national, and global levels to elevate diagnosis rates, tailor care, and effectively disseminate resources?
I think for us, I can say that I'm lucky that I live in European Union. Well, that's not the best country in European Union to live in, because Latvia has joined it only 20 years ago, and we still have huge problems, and we are still trying to catch up with the European average. And as you know, in Europe we have around 90,000 people with bleeding disorders. We have found, as I calculated, 1/3 of all people who might have a bleeding disorder in Latvia. And the diagnosis is still difficult because it's like one of those countries you say that all care is concentrated in the capital city. For us, the geographical division is crucial because the capital city lies in the very center of the country, and all other things are like, it's a very small country. We are less than 2 million people, and some of the areas are 300 kilometers away, and there's no specialist care. Even because we are so small, we can't afford having specialist care 24/7 in the capital city. Hematologists are not working there 24/7. And that, of course, makes many problems. And that's why we are advocate to get treatment at home. And it's not only for hemophilia, in which we have all patients with severe hemophilia is on prophylactic treatment. Well, it's slow dose prophylaxis, but still. And we currently are focusing our efforts as patient organization towards von Willebrand's, because that's one of the biggest patient groups, and one of those in which treatment is not here. They promised here yesterday on the plenary that we will have new achievements and new things in the next Congress, where you will be able to hear many updates for our treatment. But while we are trying to get there, we still have like huge problems. Like it's the same like in your country. We have cities in which everything is fine, and then we have local areas in which it's like not that fine. Then we have doctors who have never heard, like probably they have heard about hemophilia because it's like famous thing to have, but they have never heard about von Willebrand's or rare bleeding disorders. So every time we as patients have to go there and explain. We also have being engaged in various ministry level events that are happening. We are strengthening the patient voice as such because patients, we have the lived experience about the disease and nobody else can go and advocate for us. Many people would like to because it's fancy to be in a patient organization, but they miss the point that you have to be ill and you have to be like suffering from the same things that that makes you a patient and what gives you the energy to do this for other people like you. So I think we still have so many things to do, but I see that there are so many passionate people that can do this, and I really believe that in the nearest future there will be many new changes for us.
But obviously the situation in your country has improved, and I am convinced that thanks to you, because you are leading this big process, a long journey. But in your mind, when and how was possible to improve the diagnosis? Do you have any tips in order to share with the audience? How was possible the tipping point that explode and increase dramatically the number of diagnosed people?
I can come back to my own example. I was born, like in my family, me, my sister, and my brother, we all have von Willebrand's. And we found it out only when we were 3 children in the family because it comes from my dad's family, from his mother and his grandmother, and they kind of like didn't know that it will pass, definitely will pass to the children. And it was like it always came with lots of tears and lots of blood because there were always traumas and things like that. So, and then it took me huge amount of effort and years to convince government that we have to have included in the rare disease plan, which was also patients-led, because nobody in the from the officials wanted to work with it. We were there, we were constantly asking, where is our plan, how much money will we get for it? These are the actions that we as different patient communities, it's not just bleeding disorders, what we have to include there, what is important for patients. It's not just medicines, it's about mental health, it's about various services. There are people who need palliative care and other things like that. So for us, like being there and knocking on the doors constantly, I think that was the most important thing that allowed us get the genetic testing available for people. So I could get my final diagnosis only when I was 39. So it's like 20, how many years without knowing exact type, and that's why I couldn't ask for precise treatment, and I'm still on the way to get the treatment for myself, for my family, and other people like me.
Okay. Thank you, Barbara. James, James coming from Kenya, Africa. For sure, your situation in your country is not similar than the previous country.
No.
I have been in Kenya, I have been in the Kenyatta hospital, so I identify several problems, of course, many challenges in Kenya, of course, but I noticed that your leadership has been something that promote and the incorporation of the government. And I remember when I visited the Minister of Health, he was able to sign agreements. So how has been possible to survive hemophilia and amid many other challenges in your country?
Well, thank you. Good morning. My name is James Kago. I'm 41 years old, living with hemophilia in the best part of Africa, that is Kenya.
Can you speak louder?
Yes. I was diagnosed with hemophilia when I was 1 year old, and it wasn't easy because at the time we were purely depending on blood transfusions. It was not until 2005 that I got my first infusion of factor, and that was when we started receiving factor from the WFH. In 2014, we were able to revive Kenya Hemophilia Association, which is the national or the NMO for the country. And at the time, we had only 34 patients living with hemophilia that had actually been diagnosed. Some may not have been diagnosed correctly, but at least we had an idea that they had hemophilia. In 2000, after 2014, we embarked on what I would call a success story for Kenya, because our key focus was on 5 areas. One, we wanted to improve on the infrastructure. We didn't have a dedicated hemophilia clinic where a hemophilia patient could actually seek treatment whenever they had a bleed. We used to go to a particular office of a hematologist at the time. That has changed over the period. For the last 10 years now, because we are celebrating 10 years since we revived, we've been able to identify 957 new patients. And we have been able to establish 16 treatment centers across the country. That has reduced the travel time for patients from as high as 6 hours to as little as 2 hours within where you can actually seek care. Our diagnosis still remained quite low. I'll mention something about Kenya. Kenya has a devolved health system. We have 47 mini states, or what we call counties, in our country. And so health is devolved. So it means for you to make any policy changes, you have to also talk to those specific counties. So healthcare at those particular health facilities has to be moderated or influenced by the governors. And so even purchasing diagnostic machines for the county referral hospital has remained quite low. But one of the things that we've done is that we have a very good collaboration between the national government and the county governments. And so that has really helped us, even when we are going to the county governments, to talk to them about how to influence care within the different counties. And that has really worked. When Caesar came to Kenya, we were pushing the government to be able to allow treatment products to come into the country duty-free, because previously they were being charged. And so it was very good, because we had already been recognized by the ministry that hemophilia is actually under the non-communicable diseases. So it was easy for us to have that working relationship with the government, with the national government. So they currently waive all the taxes or the taxes associated with the donated products. So care has really, really improved, but we still have a very big challenge. Kenya has a population of 50 million people. So that means of the 957 that we have so far identified, we still have another 4,100 who we don't know where they are. Some could be severe bleeders, some may not be as severe, and that is just the hemophilia cases. We have not touched on the von Willebrand diseases, where we believe majority of the patients would be at. And so it calls for a lot of work between the government and the NMO to be able to establish where these patients are living, so that we can start at least influencing their care, and they can come out and be diagnosed. At least be diagnosed, then we can be able to offer care. Our care currently is purely on demand, meaning that I may not be able to live a good life as Chris. For us, by the time you are reaching 18 years, I remember when I was growing up, I was told the oldest you can live to be as a hemophilia patient is 18 years. But now we are trying to change that narrative, and we hope the other generation of patients who are coming in will be able to live longer. So I've been able to break my own record of living by another 5 years, because I was expected to actually double plus 5 years, because I was supposed to live up to 18. I attained 36, that was double, plus another 5, I'm 41 now. Thank you.
If I ask you, in this long journey, who has been the key person that you get like Ali, as part of the government, as part of the association, as part of the Hemophilia Treatment Center, who has been the key person in your management?
Well, in Kenya we say it is not a single individual. We all play a key role. But care didn't quite improve until when we had our current chair, who is Professor Kibet, coming in, and we sat together. At the time, I was actually the chair when he came into the program. That was in 2014. And we sat down and we said, look, hemophilia is more of a clinical condition. So when we go to the ministry to speak, and we are sitting among doctors, the Ministry of Health officials are mainly doctors. When he speaks, people will listen. When I speak, people start thinking, oh, that's a patient. How did he know about hemophilia? So we swapped roles, and I became the board treasurer, and he became the board chair. So we have been working together. We never go to the ministry, even if the ministry invites me today. I can never go to the ministry alone. I have to carry a doctor with me.
Correct.
And the doctor has to carry a patient and a parent. So our model has been carry a patient and a parent because you have to listen to their opinion. It matters in healthcare, you understand? So that is what has worked for us because we work as a team.
Okay.
Yeah.
Okay. Thank you, James.
Thank you.
So, Chris, I know that we share the same world, okay, but with different strategies. As you know, the World Federation always address our health to the government, to the country, to the state. So this is a national program that we work. But that it doesn't mean that Chris has been very important job in terms of the Save for Life, for example.
Yeah.
In several cases, I am a witness starting from zero.
Yeah.
So when we arrive in that country, something has been helping them. Usually has been people like Chris and Save for Life.
Yeah.
So it's extremely important. Do you have an idea how it's possible to continue with this model, or we have to change?
Yeah, so for those of you maybe not familiar with Save on Life, we've been around for like 23 years now, which is really exciting. And our kind of model is, I would say, very complementary to WFH in that we really try and focus on individual patients and how we can help assist them with some of the socioeconomic factors that kind of prevent good access to healthcare.
Yeah.
So, with some financial assistance, helping them get transportation to hospitals, staying in school to get educations, sometimes just using the funding to pay for food. We've heard so many stories of people that live 6 hours, 8 hours away from the hospital that has the factor. And some of these families don't necessarily have the funds to just pay for the bus ticket to get there. So they have to make this decision of whether, do I pay for my child to go on this bus to the hospital and miss 2 days of work, or do I stay and work and feed my family? And so we're trying to address some of those challenges through our program, and it's been really interesting to watch that grow from that simple program to now we've been supporting over 2,200 people through our program, and provided support to many of them for over 10 years, and watching that stability of assistance over those years, how it can really improve their lives. And one of the best parts that we've seen is it helps a lot of these kids stay in school and get educations. And when they're facing some pretty significant disabilities at a young age, getting that education and an opportunity to go to school has been really transformative. And then we also started assisting with educational scholarships and loans to help start small businesses and all these other ways to kind of tackle those socioeconomic challenges. But one of my favorite parts is seeing those guys that were in the program from early on in 2001, 2002, who are now 20 years old, 25 years old, and they're involved in their patient organizations and they're becoming leaders, and they're going to advocate, with the leaders of their organization for better access to care. Sure. And it is a pretty high resource demanding kind of model, but we very much see the transformation in those patients' lives, and definitely see it as a way to assist them while WFH and these NMOs do the really important work of building this infrastructure and support for patients. And it's been amazing. I've been going to Kenya since 2011, and I went back most recently in 2019, and the transformation in that time period has been amazing. And so if we can kind of continue at that momentum, it'll be amazing to see how we can continue and support these patients. So
you have mentioned several, for me, KPI. So in terms of the transportation, long distance, and school, whatever, usually we have been using the strategy to demand to our government, our state, because the Constitution, the human right, I had the civil rights. Do you think that kind of the argument that we have used in the past need this kind of the KPI, for example, transportation, how many days absent in school or no work, for example. What kind of the argument do you think we must implement and use nowadays?
Yeah, I mean, I think I agree. Like, I think, you know, access to care and access to healthcare it should be a human right, and that's a really critical argument. It is a human right. Did I say? I meant to say it is a human right. You know, I think you know, seeing where a lot of these families are coming from and the challenges they face, like you throw hemophilia or any other, you know, bleeding disorder or other chronic disease on top of that, like it's just such a crushing burden on these families, you know. So I think, you know, when you can prove to these organizations that like access to care and education and like that consistency results in people that are giving back to communities and employed and working and continuing to, you know, support their local communities, I think that's like such a powerful argument to use to local governments about like how important access to healthcare is. And access to healthcare is a wide range, like a very broad topic. I think it's not just medicine. You know, it's so many other factors that come to healthcare.
Excellent point. That is something that we must consider. I don't know if someone here has calculated how much is the cost of a not treated patient.
Yeah.
Because the government and the authority always pay attention how many is the cost if I have to give this treatment or new therapy, or for example, how much is the cost not treated that person. Mm-hmm. So we are in many cases defending or proposing based on the quality of life. Do you think in your case in Latvia, the government pay attention to the quality of life properly? Is something that is useful to convince the government because you have the right to be living better or not?
Like you said, sometimes these are only political figures. And then we as patients have to teach them what is health-related quality of life, what is the definition of this, what are the concepts inside of this, what is universal health coverage. Because now we have like these discussions, they are coming back about insurance models. And this is not the thing that we in Europe are striving for. We need universal health coverage, which means that we as patients have to access the most critical care we need without financial or any other hardship. So basically, government has to provide it. We have only few countries, I think, that can do this purely. All others are struggling and having different problems. But I wanted to say about these KPIs. Yesterday, I was in a meeting for core von Willebrand disease outcome measures. They were presenting that we as patients, because that is also something they are including patients as a stakeholder to come up with the things that industry should measure when they do clinical trials. And one of the things that we as patient community were able to change is that for the first time in history they have included heavy menstrual bleeding as an outcome. So for us women, that is something extra, like super important, because of heavy menstrual bleeding that is not treated, we are suffering. Sometimes it's like 1 week, 2 weeks, or in some cases even more, when we are not able to even get up from the bed because of iron deficiency and other things to feed the families. So it's not just like, oh, I don't feel well, I have stomach pain and other things that you sometimes think that we that this is like something that's just an excuse that we can't do things. It really hurts, and it has like very big consequences on a woman herself and also for the family. She can't go to work. Menstruation starts when for teenage girls, and they can't go to the school because of in some countries we do the projects to have access to menstrual products for free. And that's like, for others it might sound like a small thing. For us it's like extremely important, because these women in Europe, in Africa, in any place of the world, they just can't go to the school because they are bleeding and they have no information that 7-to-1 rule. So if it's longer than 7 days, if you need more than 2 hygienic products, or if you need to change it more often than in 2 hours, and if you have clothes that are bigger than one euro or $1 coin, then it's a sign that you have to go to the doctor and ask for the explanation what's going on. It's not always bleeding disorders, but that's like for 1/3 of these women it might be. And this is the only reason why we are trying to have equal place in this male-dominated community, because we really need the help. And I'm not even speaking about people who are dying during the childbirth or from the postpartum bleeding. So that's also one of the indicators that is included in United Nations Sustainable Development Goals. So we use this as an argument now because in Latvia, every year I read at least 3-4 stories on media where women have bled to death because somebody couldn't provide health. And I really don't know, because I don't have access to medical records, or I'm not involved in the process in which they are evaluating the reasons, but I really think that that's because of underlying undiagnosed bleeding disorder. And my goal as a woman who has seen the pain in the family when it happens, like when you have no resources, you can't go to the doctor, you can't convince them that you have to do something, there's treatment for this, you can prevent situations like that. I think that's my biggest thing to change in this world. So we are heard, and that finally there is some action that we stop this suffering that is not needed.
Thank you, Vaiva. James.
Yes.
Is this your first Congress of the WFH?
This is my first Congress.
Okay, for sure, because it happened to everybody. The first Congress is really impactful. I remember my first Congress in Montreal in 2000. So for sure, you have had the opportunity to visit several sessions.
Yes.
Me, no. That has been impossible for me. So you notice, for example, the state of the art, the future of hemophilia. So today it's normal to be talking about the prophylaxis, something like that.
Yes.
Do you think that Kenya is too far? That is too far for Kenya? That is too complicated for Kenya? If you want to make advocacy, asking to the authority to undertake this kind of the therapy?
Well, Kenya, for now, we are currently purely on demand, like I said earlier. But we do believe in my generation, in my lifetime, we will have prophylaxis, not only for children. There is a time we piloted prophylaxis for under 5, supported by WFH. And we saw amazing outcomes because the children were able to live near normal or normal lives. And the day before yesterday, I attended a session on aging with hemophilia. I'll tell you, one of the challenges we face as the older generation is our joint starts paining. And my belief is that maybe during our lifetime, the older generation of hemophilics will also get prophylaxis, and not just the children. But is the Kenyan government ready or able to offer prophylaxis at this particular time? Remember, Africa, we are grappling with many other conditions that are what the government deems more important. We have malaria, we have tuberculosis. And so when you mention hemophilia, the first thing they ask you is, how many people? And you tell them 1,000. And they ask you, we have 50 million people. 1,000 is such a small number. But like we mentioned earlier, hemophilia, in our constitution, which we passed in 2010, health is a basic human right. And so we are anchoring our advocacy on that basis, that every person is an important and integral part of the society. And it doesn't matter. If we lose one, the impact is huge. Like Caesar asked, what is the cost of not offering care? And so that has been our push. And we are working together with WFH. And our plan is, WFH currently is offering all the donations. We have been working on a mechanism where we start requesting the government through WFH that if WFH is going to give 100% this year, the next year they will give 75% and the government starts buying 25%. Possibly in the next 5 years, WFH can exit and now allow the government to continue with the program of buying the factor. But as it is right now, possibly that may happen, but we are not yet there. So it calls for a lot of advocacy, and not just that with WFH. In every forum, even with WHO, we need to, in every forum that they sit in, we need to see hemophilia being discussed, and not just hemophilia for male. I think we are now trying also to shift the discussions from the male as the only patients with hemophilia to women with bleeding disorder. Babiana has just mentioned something very, very important. We are talking to them and we're asking them, every forum we go like this, we ask them, how many ladies have menstrual problems that, or periods that last longer than 7 days? And you realize they may not be hemophilic, but the conversation is starting. Women are realizing, oh, my sister has, it is no longer a hormonal imbalance issue. It could be a bleeding disorder. We have so many families in Africa, or in Kenya in particular, who have nose bleeding issues. And nowadays we tell them, oh, if your nose bleeding, you could actually be a person living with bleeding disorder. So we are slowly stopping to just mention about hemophilia, but now we are going into the bigger bleeding disorder, space, so that hemophilia just becomes one of the elements, and the other conditions also become noticed, because there is power in numbers. So when we speak as von Willebrand together with hemophilia, together with platelet condition, then they listen, because it's affecting more people than just hemophilia patients. So that is the kind of conversation we are currently having, and we hope it will bear fruit, not today, but in the near future. Thank you.
But for sure, the first reaction from the government, from the decision maker, when you advocate, for sure the reaction was that medicine is too expensive.
It is.
All right.
Yeah.
But have you used the argument that, moreover in Kenya, the long distance that the patient have to get the transportation, how so important is the adherence of the patient and the frequency that the patient have to go, or the patient need a cell infusion? What kind of the argument, for example, with the therapy that you are implementing in your country?
So the kind of argument we are starting to have now with the government is because, and the lack we are having is, the health, like I mentioned earlier, is a devolved function. So we are going to the county governments. We have engaged the wives of the governors, or the governor is actually the leader of the county. So those are the ones we are now adopting, because they face the menstrual problem as well. And they also have the greatest impact of care when a child is sick. So they have a better understanding of health issues than men. So we are trying to bring them on board, because they're able to influence their husbands. And this can actually go to the county assembly, and county assembly can start allocating some little money. One of the benefits we've seen is, even on those 16 facilities we've established today, I think only 2 charge the patients for infusion. Remember, the pack for WFH, the donation we receive comes with a syringe, with a swab and everything. So we ask them, why we have donated to you possibly the drugs, why then do you have to charge for an infusion? And majority of them are no longer charging. So we hope that now they can start allocating resources to buy the product itself, because now at least they have waived the charges that the patients would normally incur. So that is a good step. But we believe maybe in future, as we continue to advocate with this County First Ladies Association, we may be able to get a factor into that budget of the county.
Thank you. So I want to invite you, someone want to make any question and identify with these different situations and different scenarios. Anyone want to make any question? Ahmad.
Thanks everyone. It's really nice to listen to different stories from different parts, different continents with different support and resources. I'm Ahmed and I'm from Qatar. So I would like to ask, this is a very good example. You said we reached to the government to start doing a collaboration through the wives of the government.
Yeah.
So now, because the title is building a movement, and is there a framework that, I mean, if we could not establish this close relationship and on a personal level with the government, what is the next step? I mean, involving WFH, involving other, because it's not possible in every country to reach to a personal level with the politicians, you know. And even sometimes the personal relationship, it changes. So in order to maintain a support or start a continuity of resources support, I think there should be more like a framework the WFH can help with, or even countries like United States or Chris. From your experience, what do you think? Thank you.
Oh, that's good.
I can answer if you
Yeah,
want.
you want to go for it?
I can.
Yeah.
The question is addressed to someone specific?
Yes. I mean, for anyone to answer.
All right.
Yeah.
I can tell you one thing that you can use also for your advocacy, because in the United Nations, few 2 or 3 years ago, they passed a resolution which is to improve health of people with rare diseases. I know this community is way ahead of rare diseases in other. But this is a document that won't change that quickly as the wife probably. and I think like also for us in Europe, we also have we are trying now, because healthcare is different in each country. We have Italy and Spain, which also has the system like you, where it's like a regional. But we are now trying to get a united health approach. And through these documents and policies, rare diseases is also one of the priorities for healthcare. It's cancer, it's rare diseases, and some other big diseases that they are tackling. And that is documents that we can use in advocacy. On the other hand, we also need understanding how decisions are made, and that's why in Europe we have created again a new resource to be trained in health technology assessment and how to evaluate things and how to get our arguments ready on the paper and bring it to the government, because for them we are just like one of many who are coming. So we have to be there and have to constantly repeat the needs that we have.
Please, I'm sorry, you want to say something?
Yeah, can I just add one little thing? When I think of like the U.S. and where we've been with access to medicine and changing policy, it's been a decades-long process, and I think that's one of the critical things. Obviously, well, not obviously, but in the U.S., a lot of the advocacy came after the contaminated blood, with HIV, Hep C. That brought a really strong community together and a loud voice with a very distinct need. But it was the consistency over decades that I think has led to better change. And it's something that I kind of actually worry about in the US a little bit, is like maintaining that consistency and that voice, because there are still always threats to access to care with our crazy insurance system in the US. That I'm worried if our voice, we don't continue with that strong community, that strong voice, that big network of people, that will maybe have that slide backwards. And I think that's the thing you always have to maintain and build and keep going, even though it might feel like nothing's happening, after sometimes decades, you do make progress.
Okay, Mahmoud from Saudi Arabia.
I'm Mahmoud from Saudi Arabia.
It's working?
No, you have to use it for the camera.
Yeah.
Camera, like this?
Yes.
Okay. I am Mahmoud from Saudi Arabia. From the title, Creating Innovation Led and Change in Diagnosis and Access Care to Care. So it takes me back to 25 years ago when we established our program. Also it takes me to the title, always I'm repeating in my sessions, which is education, education, education. So in that time, we don't have any registry, we don't have any number of in the kingdom, it's a very wide country, how many patients with hemophilia and rare bleeding disorders. And by cooperation with our colleagues among the whole kingdom, we reported in 2007 only 187 patients. And the last annual global survey, it's more than 2,000.
Oh.
Yes. So it came through the educational session with the nurses, physicians, lab specialists, all together and multidisciplinary team.
Yeah.
And if we come to the diagnosis, I have suggestion actually, if it can cooperate with the Ministry of Health to the primary health care centers, any patient who attend the clinic with little bleeding or any bleeding disorders, to order a simple test, to say PTA, PTT, and then it will lead us where to go. Also, if we can do some kind of activities in the universities, in the schools, like a campaign, like just a survey, and we found that it's very beneficial to make across students to do some blood tests, just PTA, PTT, and we discover a lot of patients with bleeding disorders. Well, I will stop here. It's a long story, but
No, thank you for sharing that story. This is very short question because we don't have many time. Please.
Yes, thank you, Sasa, and the panelists. I think one thing I want to mention.
Can you speak louder, please?
Okay. One thing I want to mention to James, right? The issue of our governments, especially African governments, not purchasing this life-saving clotting factors is very important.
Yeah.
So you guys need to collaborate with human rights organizations in Kenya so that at least to have a bigger voice to force these people to buy these clotting factors, because it's our human rights.
Yeah.
We all deserve a great treatment, right?
That's true.
And also to Greece, I think the issue of scholarships for our breeders is very important. We need to speak to the industry to provide additional support for our members to be educated so that they can at least have something to do going forward. Thank you very much.
Thank you. Thank you. Well, and sadly, we have to leave because for sure you have several sessions now, but I want to thank all of you because you are accepting my invitation, and I want to thank to James from Kenya, Baiba from Latvia, and Chris Bombardier from Everest. From USA. Thank you.